Hello, I am Anna Herforth. I'm with the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health in Boston, and I am delighted to join you virtually to share some new results from the Global Diet Quality Project on what is South Asia eating. We've just completed the first round of a survey across multiple countries, covering many in South Asia, which I'll share with you today, the motivation of which was to collect diet data for informed decision-making. Recognizing the diet is a critical public health risk for malnutrition in all its forms, including undernutrition, hidden hunger, micronutrient deficiencies, and diet-related non-communicable diseases. Yet, despite the huge impact of diet on public health, most countries, including in South Asia, have had no recent nationally representative dietary intake surveys in the general population. And the main reason driving this is that collecting dietary data typically requires high costs, time, expertise for both the data collection and the analysis. And so it often isn't done. Yet without diet data, it's really difficult to see the problem clearly and what is such a strong impact on nutrition and public health. We do know that access to healthy diets in South Asia is low. And coming from the State of Food Security and Nutrition in the World report last year from the United Nations, an estimated 70% of people in South Asia cannot afford the least cost form of a healthy diet in the market. And a healthy diet costs over 4 times the minimum cost of just meeting energy needs only from starchy staples. And we can see, looking in the pie chart of the cost of a healthy diet in South Asia, on average, that cost is about $3.39 at purchasing power parity international dollars. And 40% of that is coming from fruits and vegetables, and another 40% from protein-rich foods from animal source or plant source. And only less than 20% is coming from starchy staples, oils, and fats. So the cost is really being driven by the nutrient-rich, more perishable, non-staple foods. We also have seen in previous research that across the year, there's a strong seasonality to the micronutrient-rich, diverse fruits and vegetables as well, meaning that at some times of year, cost of a healthy diet and access to healthy diet is even more constrained than at other times. So we have this information based on food prices and income data, but what about what people are actually eating? The Global Diet Quality Project is a collaboration between Gallup, Harvard, and Gain, and it was formed with the aim to enable diet quality monitoring through the collection of data using a standardized tool that produces a suite of diet quality indicators that are comparable across time and geographies. So to really build a global monitoring system for diet quality that can be usable in countries as well. The Diet Quality Questionnaire, or the DQQ, was developed as a tool to rapidly assess diet quality at population level. And the approach of the DQQ is to ask yes or no questions about the foods that were consumed in the previous day. That covers 29 universal food groups. The food groups are the same across countries, but the items themselves are adapted to each country. And you can see here what it looks like. The country adapted questionnaire for India is shown here. This is the whole thing. And the adaptation was done with the help of experts around the country who gave information on the most commonly consumed items that can be sentinels of each food group and capture the majority of the population. And this questionnaire is just read aloud the same way each time, either in person or by phone, and the whole thing takes about 5 minutes to administer. The 29 food groups captured in the DQQ include a diversity of plant source foods, as well as a diversity of animal source foods and foods to limit, which tend to be high in sugar, salt, fat, saturated fat, or processed and red meat. And these food groups were handpicked in order to compute our core diet quality indicators, which are pictured here among many other indicators that can come from the DQQ. These are building on a lot of work that's been done over the past many years by the global nutrition community. So on the one hand, we have dietary adequacy indicators. One of these indicators is the minimum dietary diversity for women indicator, pictured here in the FAO guide to measurement. And this is an indicator of nutrient adequacy for women aged 15 to 49 years of age. We also have an indicator of food group adequacy called All5, which captures the percent of the population who has consumed all 5 of the food groups which are most commonly recommended across countries. And on the other hand, we have new indicators on the protection of health against non-communicable diseases. These indicators are derived from the WHO Healthy Diet Fact Sheet. The recommendations here are meant to apply globally, and they include health protective components of the diet, which are reflected in the indicator NCD Protect. It reflects consumption of abundant fruits and vegetables, whole grains, pulses, nuts and seeds, and fiber. And we also have an indicator of dietary risk factors for NCDs that increase the risk, called NCD Risk, which captures food groups associated with excess sugar, salt, total and saturated fat, and red and processed meat. The DQQ has been implemented now in the Gallup World Poll, which is a multi-topic survey covering the globe. It's been implemented so far in the countries you see in blue here, which they represent 2/3 of the world's population. And the data that I will tell you about today in this presentation cover 5 countries where data were collected in South Asia, including Pakistan, India, Nepal, Bangladesh, and Sri Lanka. Also, the DHS is using the majority of the DQQ questions, the same question adaptations, to collect data among women and infants and young children in the demographic and health surveys. So in the Gallup World Poll, which is the results I'll share today, the data were collected in nationally representative samples of 1,000 respondents per country, except for large countries. In India, 3,000 respondents were sampled, age 15 and older, including both women and men. The data were collected between July and March of last year, and most of the interviews were done face-to-face, except for in Sri Lanka, where they were done by mobile phone. And the interviews were conducted in 17 languages across the region. So what is South Asia eating? Not too surprisingly, lots of the usual suspects. We see the food groups consumed by over half of the population here, where the food group shows up in over half the population, you see a little flag. And the most commonly consumed food groups in South Asia include the staple grains, such as white rice, pulses, such as dals, sweetened tea or coffee, and fluid milk, which tend to move together in South Asia, and other vegetables, which are not dark green or orange. Also, quite a number of countries where white roots and tubers, such as potato, are common, and whole grains. The countries where breads made from atta are commonly consumed are showing up with most people consuming whole grains, and fewer consumers of fruits, fish or seafood, and sweets, but it's still over half the population in the countries pictured here. So looking at how these food groups combine in the first indicator, the minimum dietary diversity for women, I've put the South Asia results in global context here on the side. And we can see here that some of the South Asian countries are quite low for MDDW, in particular India, which has a percentage of women consuming MDDW that is significantly lower than the rest of the region, less than half of women consuming MDDW. On the other hand, in Sri Lanka, most women are consuming MDDW, which is significantly higher than the rest of the region. And we see urban and rural differences in all of the countries, although they're only significant in India and Nepal, where far fewer women are consuming MDDW in rural areas. And the country-adapted DQQ here, it addresses issues of standardization in collecting this indicator, which many countries or even projects have been interested in collecting, and builds capacity to be able to scale up measurement of this indicator much more easily than methods that were less standardized up until now. So we've partnered with DHS in standardizing the questions for each country to be able to measure the MDDW consistently. Turning to the all-5 indicator, again, looking at the rest of the world, we see here, this is the 50% line, the vertical line here, and we see that in most countries, most people are not eating diets that would even minimally follow food-based dietary guidelines. And we can see this because if no amount of the food group was consumed, then definitely people were not able to meet the recommended amount of the food groups in dietary guidelines. We know from previous work that was published by the FAO that 1.3 billion people in South Asia cannot afford a healthy diet covering these same 5 food groups. And with this data now on what South Asia is eating, what we see is that 1.3 billion people in South Asia are not consuming all 5 of the same food groups. We don't know the amounts they're consuming, but we know that at least 1.3 billion are not consuming diets consistent with dietary guidelines. And we see, again, some urban-rural differences significant in Nepal and in India, where rural people, again, are consuming, fewer rural residents are consuming all 5 recommended food groups than urban residents. I also wanted to say that the all-5 indicator is globally comparable because it covers the food groups typically recommended across countries, but countries can adapt it to reflect their own dietary guidelines. So for example, what we see here is that in India, even fewer, a lower percentage, 12% of people are consuming all of the food groups specifically recommended in India's My Plate for the Day, pictured here. Then if we turn to dietary factors related to NCDs, we see similar levels of dietary risk factors for NCDs across South Asia. So those are, again, the food groups associated with excess sugar, salt, fat, saturated fat, and processed meat. Not too much difference across countries. But when we look at the protective side, so the protective food groups of diverse vegetables, fruits, whole grains, pulses, nuts, and seeds, we see a greater consumption in the NCD Protect indicator in Sri Lanka as compared to Bangladesh, and Nepal, India, and Pakistan are sort of in the middle. One of the really surprising, striking things about the South Asia data was how little difference we see between urban and rural in consumption of packaged salty snacks, instant noodles, and soft drinks. This is different than in other regions of the world where we do see big urban-rural differences. Only in Bangladesh, in South Asia, was there significantly higher consumption of packaged salty snacks and instant noodles in urban areas as compared to rural. And only in India was there significantly higher consumption of soft drinks in urban areas as compared to rural. And the numbers you see here are generally representative. Across South Asia is about a quarter of people consuming packaged salty snacks and instant noodles, and about 13-14% consuming soft drinks on average. And we also see that in most countries in South Asia, again, with the exception of Bangladesh, we don't see a difference in consumption of these food groups between those who reported having enough money for food or not having enough money for food. So really what this data is showing is the reach of these ultra-processed types of foods into rural areas and food insecure areas where consumption is quite high, even among those who are food insecure. And these foods are available and competing with the diverse and nutrient-rich options which could be available as an alternative. So I've shared a few of the indicators with you here. These indicators that I've gone through today, as well as some other ones, are available. You can explore the data for yourself at the Food Systems Dashboard, foodsystemsdashboard.org, which is a project run by Johns Hopkins and Gain. And you can see here, I wanted to leave on a high point of diets in South Asia. It's a region of the world with one of the highest consumption of whole grains due to high consumption of products made with atta and other traditional whole grains, which there are many efforts to reinvigorate, and to an extent there is a lot of progress already made and more that could be made in that area. So some good news for diets in South Asia on whole grains. You can explore the rest of the indicators here. And to end, I'll just summarize by saying that the results we see here, they tell us something about diets in South Asia, and they also demonstrate a feasible monitoring system that can be replicated in countries in South Asia. The results and data that I've shown today are publicly available less than 1 year after data collection was completed. And the DQQ costs less than 1% the cost of a national quantitative dietary intake survey. The cost is so little because it is a much lighter, low burden module. Of course, it doesn't give quantitative information about how much of each food in detail was consumed, but it is a monitoring system for giving quite a lot of information about diets that tells us something at very low cost with very little training, simply being read aloud without further adaptation needed. And so it does not require nutrition special expertise and training, which so many other dietary intake methods do. And therefore, it offers other actors beyond Gallup, beyond DHS, a way to collect comparable data. We have shown the results here from the Gallup World Poll. DHS is also collecting data, but other national surveys and surveillance systems can easily pick up these country-adapted tools. They're publicly available, downloadable, and offer a pathway towards sustained monitoring of diets, for example, to see maybe what has happened in different seasons of the year or during the pandemic or due to the impact of shocks such as inflation, to be able to have a way to track changes in diet quality and offer actionable insights towards improving diets, nutrition, and health. Thank you so much for your attention today, and thanks very much to our generous donors who are listed here who have made this work possible, as well as our supporters who have really helped with the adaptation work across countries to produce these global public goods for being able to measure diet quality in a consistent and useful way. Thanks very much to all those who have collaborated. And thank you once again for your attention. I wish you the best for the rest of your conference.